So we had a very special session yesterday in the morning CME course. We wanted to have the opinion of the audience on what they thought were the perils and what were the opportunities, the strengths and the weaknesses of PD therapy. So we decided to have a kind of hands-on voting and hands-on opinion poll in this session. So actually what we did was a kind of SWOT analysis, so strength, weaknesses, opportunities and threats in peritoneal dialysis, and people in the audience could just bring up arguments of strong points, weak points, etc. And then we would have a vote in the whole audience to see whether other people in the audience agreed or disagreed with this statement. And I must say that some of the things that came out were quite remarkable. For example, if we look to the strong points of peritoneal dialysis, it was quite clear that about 70% of the audience thought that this was very much keen, very much related to the fact that this is a home-based treatment, so that patients get empowerment, that patients get their own hands on the therapy, and that this is probably one of the strong points of peritoneal dialysis. Other people offered that also flexibility might be some point, but there were some remarks that of course flexibility is a two-edged sword. It means also that if you want to do the treatment in a flexible way, you will need some education on how to do that. And if you only train the patients in one way to perform the treatment by themselves, this becomes very rigid. So there was a kind of discussion on that, how much flexibility you should allow for people. A third strong point for peritoneal dialysis was of course preservation of residual renal function, and we've seen in many sessions today that residual renal function is one of the cornerstones in predicting the outcome of the patient, so we want to preserve that. And there was the feeling of the audience that probably PD is the better way to go rather than HD to do that. And of course it's a continuous treatment, which means that in unstable patients, hemodynamically compromised patients, cardiovascularly compromised patients, this might be the better way to go. So these were all considered as strong points. Now, if we look to the weaknesses, and of course this is a biased audience because these are all PD believers, it was very remarkable to me that only 2% of the audience believed that the risk of EPS was of a major concern. On the other hand, ultrafiltration and membrane failure, it was not felt by any of the public that this was a threat to the treatment of peritoneal dialysis, because they all say, well, it's a kind of continuum and there might be some transfer between the different modalities. However, in contrast, burnout was very much offered and uttered there as a very strong weakness, because there was a general belief in the audience that burnout is one of the leading causes of technique failure. Might be related to peritonitis, might be related to the decline of residual renal function, making the treatment more complex, but still burnout is one of the things we should focus on in the near future if we want to avoid the weaknesses of peritoneal dialysis. Also for the infection, this was only a very small amount of people that thought that this was really a concern, a weak point of peritoneal dialysis. Space, logistics, storage room, this was considered by something like 1 in 4, a quarter of the audience, as an important limitation of the therapy, because you need of course a lot of bulk, a lot of dialysis fluids to be stored in the home. So if something can be done to get rid of that, for example online production of dialysis, this would be really a major step forward. Of course, the Achilles heels of the treatment, the threats to the treatment, are top number one as the catheter-related problems. And it's no surprise to see that this morning in the master class on catheter placement, the auditorium was completely full to capacity, because this is really perceived as one of the major problems in peritoneal dialysis, getting a good access, getting a good PD dialysis flow. And a second threat to the treatment was considered the perception bias in the eyes of the clinicians. Less so in the eyes of the nurses, but especially the physicians seemed to be very biased against PD. And it was the opinion of the audience that this was mainly due to a lack of education. It was a feeling that most physicians don't feel very comfortable with the therapy because they just lack education, because they don't know how to do that, and that's why they choose the safe option to go to hemodialysis. Might also have to be something with the personality of the physicians, most of them being rather paternalistic, or that we did not, or we are not trained to just give the responsibility to someone else, in this case the patient. And this is something very strange and something very weird to most physicians, that PD patients can do their treatment themselves and can decide for themselves. And then of course there is still the belief, but this is a minority of people, that this PD is a second-class treatment. And the majority in the audience thought that there is now enough evidence to make clear that this is not the case, and that PD is as good a treatment as hemodialysis. With regards to the opportunities in the future of peritoneal dialysis, it was thought that especially in the elderly and in the pediatric there is room for improvement, room for growth of the PD population, and also in patients with congestive heart failure or in a strategy to avoid vascular access. It's clear that PD should be promoted as a kind of first-line therapy to save vascular access, or to save vascular access in these patients. What came out as a very strong point through all these remarks and through all this analysis is that there is a lack of sufficient education. There is a lot of misconceptions, there is a lot of disbeliefs in certain treatment parameters. There is a lack of knowledge in the physicians, which causes them to opt for HD rather than for PD. So if we want to improve the PD penetration, I think education is the key word that we should try to provide to this audience. So I think this was a very nice survey. Of course, it's not a randomized controlled trial and it's a bit biased audience, but still we can learn the perceptions of the PD believers to just get more aware of those who do not believe, how they think, and how we can change their mindset to improve the penetration of PD as a therapy.